I'm here with Dr. Hartl from New York, a great name in the minimal spine surgery in the world. And we have here in the New York Mix course in order to ask some questions about surgery, about minimal invasive surgery, and about our simulation system. Roger, thank you for this opportunity in your very tight schedule.
Thank you, Louis. Great to be with you.
The first question is, I mean, the first time that we met was in NAS 2015. And what do you think? How what's your first impression for rear spine when you see that in 2015?
Well, Louis, thanks for having me here, of course. I've always been a big fan and supporter of your approach to teaching and education because, one of the biggest challenges that we've seen, of course, especially with minimally invasive spine surgery, is how to overcome the learning curve that is sometimes very significant. We just had our NICMIS meeting. We discussed yesterday, for example, the challenges of the learning curve, especially with endoscopic spine surgery, right? We know that there are a lot of surgeons who are still struggling in terms of timing. It takes a long time, sometimes these types of cases. And we heard yesterday that the learning curve for endoscopic spine surgery is anywhere between 20, 30, 40, 50, cases, right? And if you think about this, that's a lot of cases, and that's a real challenge for surgeons to acquire the skills necessary for endoscopic spine surgery. Now, at the same time, we know because we worked together, we published that using the Realist, the real spine models, for example, for tubular surgery, and to train surgeons to do a tubular decompression is extremely valuable. We've published that recently where we showed that if you do the procedure in a real spine model multiple times, it really cuts down on the time that a surgeon needs to perform the operation. Their surgical skill level increases significantly. We looked at, we videotaped surgeons, young surgeons, doing the tubular decompression in real spine models at multiple stages, multiple times. And there's significant increase in terms of surgical skills, efficiency, the time of surgery decreases. So I think that I think this is really important to consider. So for surgeons who do endoscopic spine surgery, for example, doing this in real spine models is extremely valuable. Same for tubular surgery, and same for any other spine surgery, of course. So when we first met and when I looked at these models, I mean, that was exactly what was in my mind. How can we utilize this to increase the learning curve? And I think that's the most significant accomplishment, really, that I've seen over the years.
Yes, and we work together in order to develop different models, for example, stenosis models. And what do you think? This step-by-step procedure, how we can make this possible that we can integrate the models better in the curricula in the hospitals or maybe organizations? What do you think? What will be the way? Because that is something that it moves a little bit slow.
Yeah, it is slow and it is challenging, especially it's weird because everybody talks about the learning curve and you want to find something to increase surgeon skill level, but the adoption has not been very high. Part of it may have been costs, that it is somewhat, it was expensive. I think now the pricing came down significantly. The other problem I think is that we don't really have a good infrastructure to do this. There's no real, most hospitals training programs, they're not necessarily equipped to bring in these models, set up a station, even though you don't have to, you can do it anywhere, right? We know that. You don't need to go to the operating room. You don't need a cadaver lab for this. You can do this in office space. But we don't really have the infrastructure set up. You need the instruments, you need suction, you need a microscope potentially, maybe some kind of navigation system, which you have also. But I think the infrastructure is just lacking sometimes. And sometimes it's also the knowledge is people don't even know that this exists, right? So I think getting companies involved and having companies really take this on and utilize it for their products will be helpful, because then surgeons find out about this and then they realize, well, we don't need the companies necessarily. We can also do this for our residents on our own. So those are the challenges. I think the costs, I think the infrastructure, and then people don't know about it. So So we're obviously trying to address all of those.
Yes. Right now, with these videos, we try to make more visible this kind of technologies. Last question, Roger. What about the future? What do you think is the future in the use of these kind of models, and how we can improve these models in order to support better the training and the surgery?
Well, I think the future is significant. We've seen that already in our course here, the NICMIS course. Now, we used to use cadavers exclusively, and now we actually, and cadavers are good for certain things, but if you really want to learn about the microsurgical skills required, then these models are essential. And that's why we added a second NICMIS course in the summer where we only use real spine models and we only teach basic microsurgical skills to surgeons with tubular surgery. And the best way to do that is really with real spine models. It's much better than cadavers. So we added, because we understand the value and the importance of this, we added a second course that we're doing every year in August here in New York, where we have 6 or 7 real spine stations with a microscope, and all we do is really microsurgical skills. So I think that's essential. There's certain things that cadavers are still really important for, but microsurgical skills best taught with real spine models.
Thank you, Roger, for your time. Thank you for letting me be here in New York, and we see you in August.
See you then.
Thank you.